Welcome to this video entitled Peptic Ulcer Disease. On day 1, Mrs. G.E., an 86-year-old Caucasian woman, was taken to the Accident and Emergency Department from her care home. She had a 1-week history of tiredness, weakness, and some epigastric discomfort and nausea. She had had one episode of maligna the previous day and coffee ground vomit earlier today. Her past medical history included osteoarthritis, gout, hypertension, and resting tremor secondary to anxiety. She had no known drug allergies and was taking the following prescription drugs: propranolol 40 mg up to 3 times daily when required, indomethacin 25 mg 3 times daily, Arthrotect, that is a formulation consisting of diclofenac 50 mg plus misoprostol 200 micrograms, tablets twice daily, allopurinol 100 mg daily, ramipril 10 mg daily, and simvastatin 40 mg at night. Her hematology and biochemistry results on admission were as listed below. Hemoglobin 8.3 grams per deciliter. The reference range is 11 to 13 grams per deciliter. Hematocrit 0.31. The reference range is 0.36 to 0.46. C-reactive protein 45 mg per liter. The reference range is 0 to 4 mg per liter. Packed cell volume (PCV) 0.275. The reference range is 0.360 to 0.470. International Normalized Ratio (INR) 1.01. Mean cell volume (MCV) 75 fl. The reference range is 80 to 100 fl. Sodium 141 millimoles per liter. The reference range is 135 to 145 millimoles per liter. Potassium 4.0 millimoles per liter. The reference range is 3.5 to 5 millimoles per liter. Creatinine 105 micromoles per liter. The reference range is 45 to 84 micromoles per liter. Mean cell hemoglobin (MCH) 25 picograms. The reference range is 27 to 32 picograms. Platelets 264 times 10 power 9 per liter. The reference range is 150 to 400 times 10 power 9 per liter. Urea 20.3 millimoles per liter. The reference range is 1.7 to 8.3 millimoles per liter. Her blood pressure was recorded as 115 systolic, 59 diastolic. Her respiratory rate was 24 and her pulse rate 155 beats per minute. A provisional diagnosis of upper gastrointestinal bleeding was made and she was admitted to the ward. Question 1 reads: how serious is the bleed? Her initial, pre-endoscopy, Rockall score is 3. This means that Mrs. G.E. has an 11% risk of mortality from this bleed. Upper GI bleeding is a common cause of emergency hospital admission. An upper gastrointestinal bleed can range in severity from insignificant bleeds that resolve spontaneously to major bleeds which lead to a huge loss of blood and death. There have been various attempts to predict the seriousness of a bleed from the patient's observations on admission, with the aim of focusing emergency treatment on those who really need it, thereby reducing unnecessary hospital admissions and allowing patients with minor bleeds to return home and be treated as an outpatient within 24 to 48 hours. The most widely used scoring system is the Rockall score, which predicts death and rebleeding rates pre- and post-endoscopy, shown in tables 13.1 and 13.2. In this case, the bleed is serious and the patient should be admitted for treatment as soon as possible. It is worth noting that her pulse rate was 155 bpm despite the beta blocker therapy, assuming she was taking this medicine. Pause the video and carefully scrutinize Table 13.1 summarizing the pre-endoscopy Rockel score before advancing to the next slide. Question 2 reads, what immediate treatment options should be considered? The immediate treatment options are to a. Treat shock. b. Stop bleeding or prevent rebleeding. c. Confirm the caused source of bleed. And d. Treat symptoms. Question 3 reads, how would you treat this patient's a. shock and b. symptoms? Treat the shock with plasma expansion and her nausea with metoclopramide. A. Regarding shock, Mrs. GE urgently requires plasma expanders, preferably whole blood. Her low MCV indicates there has also been some chronic blood loss. Sodium chloride 0.9%, or another isotonic crystalloid, is an appropriate interim intravenous IV fluid as it expands the extracellular fluid volume. The addition of potassium to the IV fluids is not advisable at this point, as whole blood can contain large amounts of this ion from lysed cells. B. Regarding symptom control. It is important to control Mrs. GE's symptom of nausea. Metoclopramide is an effective antiemetic as it increases gastric emptying and also acts centrally at the chemoreceptor trigger zone to relieve vomiting. It is available in parenteral and oral formulations. Question 4 reads, how would you suggest Mrs. GE's current drug therapy be managed acutely? I would suggest the clinical team stops her non-steroidal anti-inflammatory drugs, NSAIDs, and antihypertensives. The potential for non-steroidal anti-inflammatory drugs to induce mucosal damage is well recognized. Recent epidemiological studies as well as large case control studies and case reports have all demonstrated a link between non-steroidal anti-inflammatory drugs and serious upper gastrointestinal tract disease, including peptic ulcer, bleeding and perforation. In the UK, the gastrointestinal side effects of this group of drugs probably account for around 1,200 deaths per year. The complications may appear soon after the initiation of therapy. Mrs. GE's other risk factors for non-steroidal anti-inflammatory drug-induced bleeds include being aged over 60, and the use of 2 concurrent non-steroidal anti-inflammatory drugs. Other risks include concomitant use of steroids or anticoagulants, a previous history of peptic ulcer disease, abbreviated as PUD, and the use of high doses of non-steroidal anti-inflammatory drugs. Risk rises significantly with age. For example, in patients over 75 approximately 1 in 100 will suffer a bleed, and in 1 in 650 this will lead to death. The risk also varies according to the individual non-steroidal anti-inflammatory drug used. Large population studies in the UK and Italy have documented differing absolute values of risk, but the trend towards which were the safer, riskier non-steroidal anti-inflammatory drugs was similar. Ibuprofen is considered the safest, and ketorolac and azopropazone the highest risk. In Mrs. GE's case she was on diclofenac and indomethacin, which are both classed as intermediate risk, along with naproxen and phenoprofen. Diclofenac and indomethacin have a relative risk compared to ibuprofen of 1.4, that is 0.7 to 2.6, and 1.3, that is 0.7 to 2.3, respectively, according to the UK study, and a relative risk compared to placebo of 2.7, that is 1.5 to 4.8, and 5.4, that is 1.6 to 18.9, respectively. Non-steroidal anti-inflammatory drugs also appear to increase the chance of complications such as bleeding in patients with underlying ulcer disease. Non-steroidal anti-inflammatory drugs lead to between a 3 and a 10-fold increase in ulcer complications, hospitalization and death from ulcer disease. Mrs. GE is also taking propranolol for her tremor related to anxiety and ramipril for hypertension. She has lost blood, and is exhibiting some signs of shock that require correction. To help maintain her blood pressure, and prevent worsening of any shock that would be associated with rebleeding, both drugs should be temporarily stopped. It should be noted that this patient is tachycardic, pulse of 155 beats per minute, even though she has been prescribed a potentially rate-controlling beta blocker for her anxiety symptoms. Although the dose prescribed is probably too low to affect her heart rate greatly, it would be useful to check her care home medication records to see whether she has actually been receiving doses of propranolol and ramipril in the last few days. Her recent vomiting and epigastric pain may have meant that she did not receive them. Question 5 reads, what is the mechanism for non-steroidal anti-inflammatory induced ulcers? Non-steroidal anti-inflammatory drugs cause inhibition of prostaglandin synthesis. Preclinical studies suggest that two factors contribute to the pathogenesis of non-steroidal anti-inflammatory drug-associated ulcers. First, the inhibition of prostaglandin synthesis impairs mucosal defenses and leads to an erosive breach of the epithelial barrier. Second, acid attack deepens the breach into frank ulceration, and low pH encourages passive absorption of the non-steroidal anti-inflammatory drug so it is trapped in the mucosa. Question 6 reads, how effective is misoprostol at preventing non-steroidal anti-inflammatory drug-induced peptic ulcers? Misoprostol is effective at preventing chronic non-steroidal anti-inflammatory drug-related gastric and duodenal ulcers. It is less effective than proton pump inhibitors, abbreviated as PPIs, at preventing duodenal ulcers, but at least as effective at preventing gastric ulcers. It is less well tolerated than proton pump inhibitors and its use is often limited by diarrhea. Various trials of the prostaglandin analog misoprostol have proved the drug's effectiveness at preventing peptic ulcers in patients taking non-steroidal anti-inflammatory drugs. The Cochrane collaboration conducted a meta-analysis of 22 studies that assessed the long-term effect of misoprostol on the prevention of non-steroidal anti-inflammatory drug-induced ulcers. 11 of the studies, which together included 3,641 patients, compared the incidence of ulcers seen endoscopically after at least 3 months of non-steroidal anti-inflammatory drug plus misoprostol, to that of non-steroidal anti-inflammatory drug plus placebo. The cumulative incidence of gastric and duodenal ulcers with placebo was 15% and 6%, respectively. Misoprostol therapy significantly reduced the relative risk of gastric and duodenal ulcers by 74% and 53%, respectively. The problem with applying this meta-analysis to the choice of misoprostol for Mrs. GE is that the trials used variable doses, with some using 200 micrograms 4 times daily and some 200 micrograms 3 times daily. Only 6 of the 11 studies used the 200 micrograms twice daily dose that Mrs. GE was receiving as part of a combination tablet containing diclofenac 50 mg. When misoprostol total daily doses of 800 micrograms per day and 400 micrograms per day were analyzed separately, both doses significantly reduced the risk of endoscopic ulcers compared to placebo, with the higher dose demonstrating statistically significant better prophylaxis against endoscopic gastric ulcers than 400 micrograms per day, p equals 0.0055, but this was not seen for duodenal ulcers. There is less evidence to say how effective misoprostol is compared to proton pump inhibitors. The Cochrane collaboration analyzed 2 trials of 838 patients which compared the ulcer-preventing effects of proton pump inhibitors to those of misoprostol in patients taking non-steroidal anti-inflammatory drugs. One compared low-dose misoprostol, that is 400 micrograms per day, daily to omeprazole 20 mg daily. The other compared high-dose misoprostol, that is 800 micrograms per day, to lansoprazole 15 or 30 mg daily. Overall, when both trials were compared together, proton pump inhibitors were statistically superior to misoprostol for the prevention of duodenal but not gastric ulcers. In the trial looking at the dose of misoprostol, Mrs. GE was taking 400 micrograms per day. The estimated proportion of patients in remission from any type of ulcer at 6 months was 61% among those taking omeprazole 20 mg daily, compared to 48% among those taking misoprostol 200 micrograms twice daily, p-value equal to 0.001. And 27% among those taking placebo, p-value less than 0.001 for the comparisons with omeprazole and misoprostol. Of patients taking placebo, 32% had gastric ulcers at relapse, compared to 10% of patients taking misoprostol and 13% of those taking omeprazole. Duodenal ulcers developed in 12% of patients given placebo, compared to 10% of those given misoprostol and 3% of those given omeprazole. Question 7 reads, how can the cause of the bleed be confirmed, the bleeding stopped, and rebleeding prevented? Endoscopic investigation and treatment are indicated in this case. The Blatchford score states that if a patient fits all the criteria below, they are unlikely to require endoscopic treatment. A. Urea less than 6.5 millimoles per liter. B. Hemoglobin greater than 13 grams per deciliter, for males and 12 grams per deciliter, for females. C. Systolic BP greater than 110 mm of mercury. D. Pulse less than 100 beats per minute. This system had a 99% sensitivity for predicting serious bleeds when trialed in 1748 patients. The benefit of scoring patients to assess their need for endoscopy is to avoid any unnecessary associated risks, costs and staff time. Mrs. GE only has one of the 4 markers in range, so is therefore highly likely to require her bleed treating endoscopically. An urgent endoscopy was arranged for Mrs. GE. Question 8 reads, is endoscopic treatment of the bleed more effective than drug treatment? The correct response is, yes. In a trial comparing endoscopic hemostatic treatment with high-dose proton pump inhibitor treatment, the proton pump inhibitor group was associated with higher rebleeding rates and longer duration of hospital stay. Question 9 reads, what is the likelihood of the patient suffering a rebleed? As a result of the findings during endoscopy, this patient now scores 6 on the post-endoscopy Rockel score, which means that she has a 32.9% chance of rebleeding and a 17.3% mortality risk, shown in tables 13.3 and 13.4. The risk of rebleeding or death is substantial for Mrs. GE, even after her endoscopic treatment. She will require close monitoring, in a high-dependency ward if a bed is available. Pause the video and carefully scrutinize Table 13.3 summarizing the post-endoscopy Rockall score before advancing to the next slide. Pause the video and carefully scrutinize Table 13.4 summarizing the percentage risk of re-bleed and mortality associated with each Rockall score before advancing to the next slide. Question 10 reads, what test should be performed on Mrs. GE during the endoscopy? A CLO test should be performed for Helicobacter pylori. A CLO test is a sealed plastic slide holding an agar gel which contains urea and a pH indicator. A 2 to 3 mm biopsy specimen from the stomach, usually the sump of the antrum, is added to the slide. If the urese enzyme of Helicobacter pylori is present, degradation of the urea causes the pH to rise and a corresponding change in the color of the gel from yellow negative to purple positive. Helicobacter pylori is a highly motile gram-negative bacterium that colonizes the mucus layer of the stomach. It is one of the commonest pathogens in man, and has been recognized as the principal cause of peptic ulcer disease and the main risk factor in the development of gastric cancer. It is found in the gastric mucosal surface of 85 to 100% of patients with a duodenal ulcer and 70 to 90% of those with a gastric ulcer. It is not known how Helicobacter pylori infection is usually acquired and its route of transmission is unknown, although gastro-oral or fecal-oral routes are probable. The prevalence of Helicobacter pylori infection increases with age in the developed world and is higher in developing countries, leading its acquisition to be linked with social deprivation. The poorer socioeconomic conditions when this patient was born mean that she is much more likely to be infected than a child who is born in the UK today. Infection with Helicobacter pylori initially induces an acute inflammatory gastritis which persists for life. A single patient may be infected with multiple strains of the organism. This is particularly common in the developing world, and in colonized hosts the organisms may mutate over decades. Different strains are now being linked with different gastric diseases, and in future genotyping could help identify people at risk of particular diseases. Some strains of Helicobacter pylori appear to exert a protective effect against certain diseases, gastroesophageal reflux, Barrett's esophagus, adenocarcinoma of the esophagus and gastric cardia, leading to controversy over when to eliminate the organism. Around 15% of infected individuals will go on to develop peptic ulcer disease or gastric cancer. It is thought that in patients with Helicobacter pylori-induced antral gastritis there is a loss of regulatory feedback, together with an intact and undamaged acid-secreting gastric corpus, and that the consequent high acid load reaching the duodenum leads to duodenal gastric metaplasia. These islands of gastric metaplasia are then colonized by Helicobacter pylori, which leads to duodenitis and a high risk of duodenal ulcer. In patients with pangastritis, an inflamed corpus results in a loss of acid-secreting cells, which leads in turn to an increased risk of gastric ulcer and gastric cancer. A CLO test has a high specificity, that is 90 to 95%, and sensitivity, that is 90 to 95%, for detecting the presence or absence of infection in the gastric mucosa. Its sensitivity is higher than that of other biopsy methods. However, it is recommended that multiple biopsy specimens be taken to achieve the highest sensitivity, as infection is often patchy. Up to 14% of infected patients do not have antral infection, but do have Helicobacter pylori elsewhere in the stomach. A careful drug history should be taken from the patient before a CLO test is performed. Antibiotics or bismuth salts taken in the 3 weeks prior to biopsy may suppress Helicobacter pylori growth, making the organism difficult to detect and leading to a false negative result. In contrast, a false positive result can occur if the patient has a chlorhydria, e.g. after taking high doses of an H2 receptor antagonist or a proton pump inhibitor. Alternatively, proton pump inhibitors can affect the pattern of Helicobacter pylori colonization of the stomach and compromise the accuracy of antral biopsy. For these reasons, it is recommended that patients who have taken these drugs prior to endoscopy have multiple biopsies taken from the antrum and corpus for histology, plus either culture or urease testing, or are tested for Helicobacter pylori once the ulcer has been treated. In primary care, when patients are exhibiting symptoms associated with Helicobacter pylori, but not actively bleeding, carbon-13, 13C, urea breath testing, sensitivity 95%, specificity 96%, and stool antigen tests, sensitivity 95%, specificity 94%, can also be used to test for Helicobacter pylori. Serological testing, sensitivity 92%, specificity 83%, is less accurate and therefore not recommended. An endoscopy was performed and active duodenal bleeding was noted and treated. Following the procedure, Mrs. G.E. was admitted to the medical high dependency unit. The consultant wanted an acid-suppressing drug to be prescribed. Question 11 reads, which acid-suppressing drug, and what dose regimen and route would you suggest? What evidence is there to support your recommendation? What alternatives could be used? A high-dose IV bolus of the proton pump inhibitor omeprazole 80 mg should be given, followed by an infusion of omeprazole 8 mg per hour for 72 hours, followed by high-dose oral proton pump inhibitor therapy for 5 days. Alternative therapies include somatostatin and antifibrinolytics. The effect of acid suppression in patients with active or recent ulcer bleeding has been widely studied. If intragastric pH can be maintained at 6 or above, peptic activity is reduced, platelet aggregation, clot formation, is improved, and clot lysis is inhibited. These effects should help to stabilize the clot over an ulcer, promoting healing and reducing the chance of the ulcer rebleeding. Meta-analysis of the effects of histamine H2 antagonists on clinically important outcomes associated with duodenal ulcers showed no significant difference compared to placebo. This is likely to be because H2 antagonists are not effective enough at increasing gastric pH above 6. Proton pump inhibitors have been shown to reduce the rate of re-bleeding and the need for surgery in patients with peptic ulcer bleeding. For this reason, they are the drug class of choice in this situation. However, proton pump inhibitors do not significantly affect mortality in patients suffering from bleeding ulcers. Both oral and IV proton pump inhibitors have been shown to reduce re-bleeding and the need for surgery. In patients who have not had a major bleed requiring endoscopic treatment, an oral proton pump inhibitor would be an appropriate and cost-effective treatment. One trial showed that oral omeprazole 40 mg twice daily for 5 days reduced re-bleeding rates to 11%, versus 36% in the placebo group. In cases such as Mrs. G.E., where endoscopy is needed, high-dose IV treatment is required. Various regimens have been trialed, including high bolus doses or infusions, but none has been adequately powered to draw conclusions from head-to-head comparison of the different regimens. Omeprazole 80 mg IV stat, then 8 mg per hour infusion for 72 hours has been shown to reduce recurrent bleeding to 6.8% versus 22.5% for placebo, NNT equals 6, and blood transfusions to 2.7 units versus 3.5 units for placebo. This regimen is therefore considered the gold standard. After 72 hours of proton pump inhibitor infusion, a high-dose oral proton pump inhibitor should be prescribed. Again, various doses and frequencies have proved effective. Omeprazole 40 mg twice daily orally for 5 days after endoscopy has been shown to reduce rebleeding to 7% versus 21% in the placebo group, NNT equals 7. Omeprazole 20 mg 4 times daily orally led to rebleeding rates of 17% versus 33% in the placebo group, NNT equals 6. It can be argued that twice-daily dosing is preferred by most patients and the nurses who have to administer the drugs. Alternative therapies include somatostatin and antifibrinolytics such as tranexamic acid. High-dose IV somatostatin suppresses acid secretion and splanchnic blood flow and is theoretically an attractive therapy. However, although a meta-analysis of available trials showed some benefit, the quality of much of the data was poor, and this drug is not routinely used for the management of bleeding peptic ulcers. A meta-analysis of trials using tranexamic acid, which inhibits fibrinolysis, has demonstrated that the drug does not appear to reduce rebleeding, but does reduce the need for surgical intervention and may reduce mortality. However, the overall benefits are unclear and further trials are needed. Mrs. GE was prescribed omeprazole 80 mg intravenously IV to be given immediately, followed by an 8 mg per hour omeprazole infusion for 72 hours, then omeprazole 40 mg orally twice daily for 5 days. Her Helicobacter pylori test was reported as positive. Question 12 reads, does infection with Helicobacter pylori predispose to non-steroidal anti-inflammatory drug-induced damage to the gastrointestinal mucosa? There is now good evidence to suggest that the presence of Helicobacter pylori predisposes to non-steroidal anti-inflammatory drug-induced ulceration. Non-steroidal anti-inflammatory drug ingestion can lead to a variety of gastrointestinal injuries, ranging from petechial hemorrhages to erosions and, occasionally, ulceration. However, the move from erosion to ulceration is not necessarily inevitable, and endoscopic studies have shown that non-steroidal anti-inflammatory drug-induced erosions can appear and disappear over time, presumably as a result of adaptation and repair processes. Investigations into the relationship between long-term non-steroidal anti-inflammatory drug use and Helicobacter pylori infection have concluded that non-steroidal anti-inflammatory drug-induced damage to the gastroduodenal mucosa does not increase susceptibility to Helicobacter pylori infection, but that ulcers are more likely to develop in long-term non-steroidal anti-inflammatory drug users who are infected with Helicobacter pylori, especially if they smoke. Meta-analysis has suggested that both Helicobacter pylori infection and non-steroidal anti-inflammatory drug use independently and significantly increase the risk of peptic ulcer and ulcer bleeding. In addition, there is a synergy for the development of peptic ulcer and ulcer bleeding between Helicobacter pylori infection and non-steroidal anti-inflammatory drug use. The presence of Helicobacter pylori infection has been shown to increase the rate of peptic ulcer disease in non-steroidal anti-inflammatory drug takers 3.5-fold, compared with the risk associated with non-steroidal anti-inflammatory drugs alone. The risk of ulcer bleeding with Helicobacter pylori and non-steroidal anti-inflammatory drug use separately was 1.8 and 4.6, respectively. This increased to 6.1 when both factors were present. To try to establish whether eradication of Helicobacter pylori reduces the risk of non-steroidal anti-inflammatory drug-induced ulceration, a study of patients with a history of dyspepsia or peptic ulcer disease who were non-steroidal anti-inflammatory drug naive but Helicobacter pylori positive, via urea breath test, were randomized to either eradication therapy or proton pump inhibitor therapy alone for 1 week prior to commencement of the non-steroidal anti-inflammatory drug. 90% of patients in the treatment group had Helicobacter pylori eradicated. After 6 months, treatment with modified release diclofenac 100 mg daily. 5 of 51 patients in the treated group and 15 of 49 of the group treated with omeprazole alone prior to therapy had ulcers. In another trial in patients with previous peptic ulcer and prescribed non-steroidal anti-inflammatory drugs, Helicobacter pylori eradication reduced the recurrence of peptic ulcer from 18% to 10%. In patients using non-steroidal anti-inflammatory drugs without peptic ulcer disease, Helicobacter pylori eradication reduced the risk of a first occurrence of peptic ulcer. In a single trial of 8 weeks duration, first occurrence was reduced from 26% to 7% of patients. Question 13 reads, what other factors could have contributed to Mrs. G.'s duodenal ulcer, and might potentially increase the chances of relapse? The correct answer is her age. Mrs. G.E. is over 60, which is a non-modifiable risk factor for peptic ulcer disease. Other risk factors, which do not apply to Mrs. G.E., for non-steroidal anti-inflammatory drug-induced bleeds include a previous history of peptic ulcer disease and concomitant use of steroids or anticoagulants. Cigarette smoking has been demonstrated in controlled trials to impair ulcer healing and promote ulcer recurrence. Many mechanisms have been suggested for this effect. Other possible lifestyle factors that have been implicated as predisposing to peptic ulcer disease include stress and a significant alcohol intake. Although it has been difficult to study these risk factors under controlled conditions, there is mounting evidence that stress may function as a cofactor with Helicobacter pylori, either by stimulating the production of gastric acid or by promoting behavior that causes a risk to health. Finally, genetic factors may determine susceptibility to peptic ulcer disease. Mrs. G.'s consultant wanted to eradicate the bacteria. Question 14 reads, when should Helicobacter pylori eradication begin? Eradication should take place after the ulcer has been healed. Full-dose proton pump inhibitor therapy should therefore continue for 2 months before Helicobacter pylori is eradicated. NICE recommends that patients with duodenal ulcer follow one of 3 pathways, depending on their Helicobacter pylori status and whether or not their ulcer is associated with non-steroidal anti-inflammatory drugs. Patients who are Helicobacter pylori negative should receive 1 to 2 months of full-dose proton pump inhibitor, e.g. omeprazole 20 mg daily, or a histamine H2 antagonist if a proton pump inhibitor is unsuitable, then be reviewed for response. This is sufficient to heal peptic ulcers in the majority of patients. Those who respond but remain symptomatic can continue on a low dose of proton pump inhibitor, e.g. omeprazole 10 mg daily if or when required. Those who have non-steroidal anti-inflammatory drug-related ulcers and who are Helicobacter pylori positive should receive eradication therapy as soon as possible. Helicobacter pylori eradication therapy increases duodenal ulcer healing in Helicobacter pylori positive patients. After 4 to 8 weeks, patients receiving acid suppression therapy average 69% healing. Eradication increases this by a further 5.4%, NNT equals 18. Helicobacter pylori eradication therapy also reduces duodenal ulcer recurrence in Helicobacter pylori positive patients. After 3 to 12 months, 39% of patients receiving short-term acid suppression therapy are without ulcer. eradication increases this by a further 52%, NNT equals 2. In this case, where the ulcer is at least partly attributable to the non-steroidal anti-inflammatory drugs but the patient is also Helicobacter pylori positive, the recommendation is to heal the ulcer with 2 months of full-dose proton pump inhibitor, then to eradicate the Helicobacter pylori. This is because in patients with peptic ulcer who are using non-steroidal anti-inflammatory drugs, Helicobacter pylori eradication does not increase healing compared to acid suppression therapy alone in trials of 8 weeks duration. However, in patients using non-steroidal anti-inflammatory drugs with a history of previous peptic ulcer, Helicobacter pylori eradication reduces the recurrence of peptic ulcer. In a single trial of 6 months, duration recurrence was reduced from 18% to 10%. The consultant prescribed omeprazole 20 mg daily to continue for 2 months. After a week of observation in hospital, the patient's symptoms had resolved and her blood results were normalizing. She was discharged back to her care home to complete the treatment. Question 15 reads, outline a pharmaceutical care plan for Mrs. G.E.'s further treatment. The pharmaceutical care plan should include the following elements. A. Ensure appropriate therapy is prescribed to heal her ulcer and eradicate Helicobacter pylori. B. Ensure her analgesic therapies are reviewed and appropriate alternatives to non-steroidal anti-inflammatory drugs prescribed for future use. C. Ensure her antihypertensive therapy is restarted when appropriate. D. Ensure that her gout and any new chronic conditions are managed appropriately in view of this new diagnosis. E. Review the need for oral iron therapy. F. Counsel Mrs. G.E. on her medications. This will include ascertaining whether she manages her own medicines in her care home, or whether they are administered to her. G. Ensure her general practitioner is clear about how to manage her therapies after discharge. Question 16 reads, in the patient's discharge letter, what would you recommend the general practitioner prescribes to eradicate the Helicobacter pylori? Triple therapy with a proton pump inhibitor, amoxicillin and clarithromycin 500 mg, also known as the PAC 500 regimen. This comprises omeprazole 20 mg twice daily plus amoxicillin 1 gram twice daily plus clarithromycin 500 mg twice daily for 7 days. A proton pump inhibitor, metronidazole, clarithromycin 250 mg, also known as PMC 250, regimen would be an appropriate alternative, especially if the patient was penicillin allergic. The eradication of Helicobacter pylori can lead to a cure for patients with peptic ulcer disease. The National Institutes of Health consensus meeting in 1994 and the European Helicobacter Study Group in 1996 both recommended that the infection is eradicated in patients with active peptic ulcer disease and proven infection. Mrs. G.E. falls into this category. Eradication of Helicobacter pylori is a challenging task. Although many antibiotics are bactericidal to the organism in vitro, even high-dose regimens have proved ineffective in vivo. Possible reasons for this are that bactericidal concentrations are not achieved in the gastric mucosa, the drugs are inactivated or ineffective at low pH, or a combination of these factors. To be effective, antibiotic therapy must therefore be combined with either bismuth chelate or acid suppressant therapy or both. The rationale for the use of acid suppressant therapy with antibiotics is to increase gastric pH, thereby inducing a favorable environment for antibiotic activity. In addition, omeprazole has been observed to reduce antral colonization by Helicobacter pylori, presumably by disturbing its environment, although the effect is only temporary and colonization returns to normal on cessation of therapy. Many regimens have been evaluated for the eradication of Helicobacter pylori. Early dual therapies of omeprazole, 40 mg daily, plus amoxicillin, 750 mg twice daily, or clarithromycin, 500 mg 3 times daily, although fairly well tolerated, led to mean eradication rates of only 50 to 60%. Bismuth chelate can lyse Helicobacter pylori in 30 to 90 minutes in vitro. However, it is not clear whether the compound is bactericidal or bacteriostatic to the organism in vivo. If bismuth chelate is used as sole therapy, Helicobacter pylori eradication rates are low. However, when combined with antibiotics, eradication levels are much higher. The mechanism for this synergistic effect is unclear. Triple therapies of bismuth chelate plus 2 antibiotics, metronidazole 400 mg 3 times daily plus amoxicillin or tetracycline 500 mg 4 times daily, raise the eradication rate to approximately 80%. However, the regimen is very complex to take and the side effects can be considerable and frequent, seen in 20 to 50% of patients, which means that non-adherence, whether intentional or not, can lead to treatment failure. The addition of a proton pump inhibitor to this regimen, quadruple therapy, increases the eradication rate to greater than 90%. However, side effects and non-adherence remain significant issues, even in well-supported patients. As a result, proton pump inhibitor-based triple therapy comprising a proton pump inhibitor plus 2 antibiotics has become the recommended first-line treatment for Helicobacter pylori eradication. It is simple, effective, and much better tolerated than earlier regimens. A 1-week course has a success rate of around 80 to 85%, and may also reduce the long-term risk of gastric cancer. In patients with diagnosed peptic ulcer, increasing the course to 14 days duration improves the effectiveness of eradication by nearly 10%, but does not appear cost-effective. As the drugs need only be taken twice daily, adherence is easier. The proton pump inhibitor should be given at twice the therapeutic dose. The choice of antibiotic is usually clarithromycin twice daily. The dose is 250 mg if with metronidazole, or 500 mg if with amoxicillin. Either amoxicillin 1 gram twice daily or metronidazole 400 mg twice daily is the second antibiotic. The choice will usually depend on local drug prices and the patient's allergy status, but is also influenced by antibiotic resistance. If amoxicillin or clarithromycin has been given to the patient for any infection in the last year, resistance may be present and the antibiotic should not be used as part of Helicobacter pylori eradication therapy. Question 17 reads, should Mrs. GE be prescribed iron therapy, and if so, for how long? The correct response is, yes. Ferrous sulfate 200 mg twice daily for 1 month is appropriate. Although Mrs. GE's hemoglobin result is now almost normal, her admission hematology demonstrated a microcytic, hyperchromic picture indicating that she had been bleeding chronically. As a result, her iron stores are now likely to be depleted. Approximately 120 mg of elemental iron daily in divided doses should ensure adequate iron absorption, and 1 month of therapy should be enough to replenish iron stores. If this form of iron is poorly tolerated, a formulation such as ferrous gluconate, which contains less elemental iron per tablet, could be tried, as gastrointestinal toxicity appears to be in direct proportion to the concentration of iron in the gut. Question 18 reads, What counseling should Mrs. GE be given in preparation for discharge to optimize successful treatment and adherence to treatment? A. By providing appropriate discharge medications and counseling for each item prescribed. B. By ensuring Mrs. GE is clear about her future therapy needs. C. By reinforcing the general counseling and advice provided earlier in her hospital stay. The extent of the counseling will depend upon whether or not Mrs. GE manages her own medicines in her care home. If she does not, it is important that any counseling offered is tailored to her established needs and any necessary additional information provided with the medications for the care staff. Non-adherence is an important reason for the failure of Helicobacter pylori eradication regimens. It is vital that Mrs. GE understands the importance of completing this prescribed treatment. A medication record card plus any relevant information leaflets may help her if she is self-medicating after discharge. It is also vital that she understands how long each aspect of her treatment will be continuing. Mrs. GE completed the Helicobacter pylori eradication therapy and remained well and symptom-free. Her care home arranged for her to be reviewed by her general practitioner. Question 19 reads, should the general practitioner check to see whether the Helicobacter pylori eradication was successful? If so, how? The correct response is, it is not necessary to recheck the patient's Helicobacter pylori status, unless she becomes symptomatic. If patients with duodenal ulcer respond symptomatically to the ulcer healing dose of proton pump inhibitor and eradication therapy, then there is no need to retest for Helicobacter pylori to ensure eradication. If the patient is anxious about the result, then a retest can be performed. Provided the patient adhered to the treatment regimen, remains symptom-free and the non-steroidal anti-inflammatory drug has been stopped, there is no reason to believe that the patient has not been cured. The major causes of the ulcer have been removed and the ulcer healed. In patients who do not respond, or who relapse, retesting using carbon-13 urea breath testing is recommended. However, non-adherence with treatment, surreptitious or inadvertent non-steroidal anti-inflammatory drug or aspirin use, and ulceration due to ingestion of other drugs should first be ruled out. Question 20 reads, for how long does Mrs. GE need to be prescribed a proton pump inhibitor? The proton pump inhibitor should be prescribed for a maximum of 2 months. 2 months treatment with a full dose of proton pump inhibitor has been shown to heal the majority of ulcers. Combined with stopping the non-steroidal anti-inflammatory drugs and eradicating Helicobacter pylori, this should be considered adequate to prevent recurrence. If symptoms recur following the initial treatment, a proton pump inhibitor could be offered with the advice that it should be taken at the lowest dose possible to control symptoms, with a limited number of repeat prescriptions. There could also be a discussion with Mrs. GE about using the treatment on an as-required basis to manage any symptoms. Mrs. GE told the nursing staff in her home that her knees were painful, and that she was worried that the gout in her toe would return. Question 21 reads, how would you recommend her general practitioner manages her osteoarthritis? Treat the osteoarthritis using paracetamol 1 gram 4 times daily. It is important to try to treat the pain associated with osteoarthritis but to avoid non-steroidal anti-inflammatory drugs if possible. Paracetamol alone may control the pain, and is very well tolerated and safe at licensed doses. Mrs. GE may have a better analgesic effect if she takes it regularly 4 times a day than if she uses it just when required. If paracetamol alone is insufficient, low doses of a weak opioid, codeine or dihydrocodeine, could be added. The lowest effective dose should be found to avoid unnecessary opiate side effects, constipation being most common in the elderly. Initially, it might be helpful to prescribe small doses, 15 mg 4 times daily when required, of dihydrocodeine or codeine to assess her requirements. Depending on the amounts Mrs. GE needs, the prescription could be left to be taken when required, or given regularly either as separate drugs or as part of a co-analgesic with the paracetamol, such as co-codamol or co-didramol. It is important to assess the amount of opioid needed before starting a co-analgesic, as they offer no flexibility in the amount of opioid given. Opioid cannot be omitted if side effects are experienced without omitting all analgesia. Low-strength buprenorphine patches 5 micrograms per hour offer similar amounts of opiate to the oral weak opiates codeine and dihydrocodeine, and may be easier for Mrs. GE to use as they would reduce the number of tablets she needs to take each day. If constipation due to the oral opiates limits the effectiveness of analgesia, she may tolerate the buprenorphine patches better. Question 22 reads, how would you recommend her general practitioner manages her gout?
Thank you.